Hey, welcome back to Not So Complicated, and today we are presenting on heart murmurs and everything you need to know about heart murmurs, right? So let's begin without further delay. So the overview of heart murmurs is that heart murmurs are abnormal sounds caused by turbulent blood flow within the heart or great vessels detected via auscultation, right? So turbulent blood flow, what causes actually turbulent blood flow? The normal flow of blood in our body is laminar, right? If the blood flow becomes turbulent, that is assessed as murmur. So the most common causes of heart murmurs are valvular dysfunction, congenital defects, or altered flow dynamics, and murmurs are classified by timing, like systolic, diastolic, or continuous, and also graded by Levin's grading method, either from 1 to 6 based on intensity. Let's talk about that. Heart murmurs, there can be shunt murmurs or flow murmurs. Shunt murmurs means there is abnormal connection between two different compartments of heart, right? So like atrial septal defect, ventricular septal defect, and patent ductus arteriosus. And flow murmurs is either systolic or diastolic based on the phase of cardiac cycle. So Levin's grading of heart murmur, there are 6 grades. Grade 1 is that the murmur is very faint, may only be heard by an expert, not heard in all positions, and there is no thrill associated. Grade 2 is it is very soft, heard in all positions, and there is no thrill associated. Grade 3 is that it is moderately loud and there is no thrill associated. Grade 4, it is loud and associated with a palpable thrill. Here you come the thrill, right? The thrill starts from grade 4 only. And grade 5, it is very loud with thrill, heard with a stethoscope partly off the chest. And grade 6 is the loudest with thrill, heard with stethoscope entirely off the chest, just above the precordium, not touching the skin. Even if you don't touch the skin, it is heard in grade 6, right? So that is the grading. Let's talk about the physiological basis of this murmur. So the smaller the orifice between two compartments, the higher the pressure gradient, the increase in the turbulence in one compartment, and that is heard as a murmur on auscultation. Example case is that in the case of aortic stenosis, remember, there is narrowing of aortic valve, right? And that causes obstruction to the ventricular outflow during systolic phase, and that will increase pressure in left ventricle because there is increased pooling of blood in left ventricle, and that will increase the pressure gradient. And the more is pressure gradient, the more is turbulence in left ventricle, and that turbulence is assessed as systolic murmur. That is the example case. That is the pathophysiology behind the murmurs actually. So let's start from the shunt murmurs, the ventricular septal defect. The pathophysiology of BSD is that it is a congenital defect in the ventricular septum, allows blood to shunt from high pressure left ventricle to the low pressure right ventricle. Rarely, ventricular septal defects occur post myocardial infarction too, and the chronic shunting may lead to Eisenmenger syndrome. We'll talk about Eisenmenger syndrome in coming classes. This is a very important topic. Reversing the shunt due to pulmonary hypertension. Actually, we have talked about Eisenmenger syndrome in our cardiovascular pathology session in USMLE Step 1 first aid line by line sessions, right? So if you haven't looked at that, you can look at that. So the timing of this murmur is that it is systolic, holosystolic due to continuous shunting during ventricular contraction. And the link I have provided in here, you cannot probably click on that, so I will provide the link in description, and you can visit to hear all kind of heart murmurs, normal heart sounds, splitting of heart sounds, and all heart sounds, and that is freely available. So I'll provide that in the description. Okay, so the characteristic of ventricular septal defect in a heart murmur of ventricular septal defect is that it is very harsh murmur, almost grade 2 to 4, and it is heard at the left third to fourth intercostal space, that is tricuspid area, and it may be accompanied by a thrill. Okay, because the thrill association starts from grade 4, right? So the associated findings of murmur are that there is loud S2, that is due to pulmonary hypertension, and right ventricular heave or cyanosis in Eisenmenger syndrome. The Manuvier is that, like, Manuvier is something that can either diminish or that can increase the intensity of murmur, right? So these are the Manuviers. The heart murmur, it decreases with hand grip because there is increased afterload, and that reduces shunt gradient. So that is why in hand grip the maneuver like murmur in BSD will decrease, and it will increase with high flow states like anemia. If a patient is suffering from anemia and he has a BSD, then there will be exaggerated murmur heard in auscultation. So that is how you remember. And the other is patent ductus arteriosus, and also the pathophysiology is failure of the ductus arteriosus to close postnatally results in a shunt from the aorta to the pulmonary artery. Obviously, it is very obvious, and persistent patency is associated with prematurity or hypoxia, and left to right shunting increases pulmonary flow, risking pulmonary hypertension. The timing of this murmur is that it is continuous, spanning systole and diastole due to constant pressure gradient. I will show the picture at the last, right? I'll show the picture of these characteristics and these timings at last. So, the characteristic of patent ductus arteriosus murmur is that it is machine-like murmur, grade 2 to 4 again, and it is heard at the left second intercostal space, may include a widened pulse pressure, and the associated findings are there. There are bounding pulses in the case of PDA. Left ventricular hypertrophy can be there, a respiratory distress in neonates. The maneuvers is that it intensifies with hypoxia because of increased shunting, and it diminishes with indomethacin because indomethacin promotes closure of the shunt, right? That is why it will diminish from indomethacin administration. And also it will intensify with hypoxia. And we will not talk about atrial septal defect here because the murmur heard in AST is very, very faint because the pressure gradient between two compartments is very less, and 8 to 10 mmHg is present in left atrium, and also 2 to 4 mmHg of pressure in right atrium. So the gradient is very small, and also atrial septal defect murmur are not heard due to this reason, right? So we will not talk about that. Let's talk about flow murmurs, and first we will talk about systolic flow murmurs, and that belongs aortic stenosis. I will provide you a very, very nice way of remembering systolic flow murmurs and diastolic flow murmurs, and you can it will be in a tip of your tongue forever. So, aortic stenosis, the pathophysiology is the narrowing of the aortic valve, commonly from age-related calcification or congenital bicuspid valve, and it obstructs left ventricular outflow. We have talked about it already, and this increases afterload, leading to left ventricular hypertrophy and reduced cardiac output. Right, the timing is systolic, and crescendo decrescendo ejection murmur due to turbulent flow across the stenotic valve. So crescendo decrescendo actually means that it slowly reaches to a peak level and then tapers again. That is crescendo decrescendo. And there is another type that is holosystolic, and there is decrescendo crescendo. We will talk about this pattern at the last also, because there is a chart, entire chart for that. So the characteristics of this murmur is that it is harsh murmur, grade 2 to 4, and it is heard at the right second intercostal space, radiating to the carotids, and it is often preceded by an ejection click in younger patients, right? So the associated findings is there will be a classic triad like angina, which is chest pain, syncope is fainting, and heart failure. So there will be classic triad of this, and pulsus parvus et tardus, that is weak delayed carotid pulse can be felt. And as for gallop, from stiff ventricle will be seen, right? The maneuver is that it will be intensified with squatting. Increased preload enhances flow, and that is why it will intensify with squatting, and it will diminish when done Valsalva maneuver, because there will be reduced preload in Valsalva maneuver. Okay. That is, you have to remember these maneuvers because these are very high yield USMLE first aid points, right? So other thing is mitral regurgitation in systolic flow murmurs. So the pathophysiology is that it is an incompetent mitral valve allows backflow from the left ventricle to the left atrium during systole, and the causes include mitral valve prolapse, rheumatic fever, papillary muscle rupture post myocardial infarction, and also chronic regurgitation causes left atrial dilation and pulmonary congestion. This left atrial dilation you can see in a chest x-ray by the wide angle, like the widened angle of carina. Actually, it is only 90 degree between the angles like right bronchus and left bronchus in the carina point. That is the point where the trachea bifurcates in T4 to T5 level. So actually the normal angle between these two regions is 90 degree. But if there is left atrial dilation, you will see the widening of this angle almost 100 to 102 degree, and the pulmonary congestion can be seen by increased bronchovascular markings in left 1/3 lateral position, right? So if you haven't seen how to read a chest x-ray, you can visit the channel, so there will be a video to read a chest x-ray in 30 minutes in all kind of lesions, right? The timing of this murmur is that this is systolic, holosystolic due to continuous backflow. The characteristics of this murmur: it is blowing murmur, grade 2 to 4. It is hard at the apex, that is fifth intercostal space. More precisely, it is half an inch lateral, half an inch medial to the fifth intercostal space, right, in left side, radiating to the axilla. It may include an S3 gallop, that is third heart sound, and due to volume overload, right? The associated findings are left atrial enlargement, pulmonary edema, or atrial fibrillation in severe cases. The maneuvers is that it intensifies with squatting due to increased preload and diminishes with Valsalva, and also hand grip, that is increased afterload, enhances murmur by increasing regurgitation. So that is what you have to remember in systolic flow murmurs. Let's talk about diastolic flow murmurs, mitral stenosis. The pathophysiology is that there will be a thickening and narrowing of the mitral valve, primarily from rheumatic fever, obstructs blood flow from the left atrium to the left ventricle. This increases left atrial pressure, causing pulmonary congestion and right heart restraint. This is very simple, right? The timing of this murmur is, it is diastolic, obviously, and every murmur in diastolic phase will be low pitched, rumbling murmur with an opening snap due to stiff valve opening will be there. The characteristic is it is hard at the apex in left lateral position, grade 2 to 4. It is preceded by a loud S1 and opening snap closer to the S2 in severe stenosis. The associated findings of this murmur are left atrial enlargement, atrial fibrillation, and pulmonary hypertension or right ventricular failure, and Graham Steele murmur, that is pulmonary regurgitation, can be seen in advanced cases. That is Graham Steele murmur. You have to remember this. The maneuver is that it will intensify with exercise due to increased heart rate, that shortens diastole, and increased turbulence, right? So other we have is aortic regurgitation. The pathophysiology is incompetent aortic valve that allows backflow from the aorta to the left ventricle during diastole. It causes include aortic root dilation, that is in Marfan syndrome, and aortic knuckle or aortic knob you can see very enlarged in chest X-ray, and endocarditis or rheumatic fever. Chronic regurgitation leads to left ventricular dilation and eccentric hypertrophy. That eccentric hypertrophy means the myocardial fibers are like arranging in series instead of parallel, right? If in pressure related left ventricular hypertrophy, there will be concentric hypertrophy due to the myocardial fibers arranging in parallel, but in this case they are arranging in series, and the timing is diastolic. This is high pitched decrescendo murmur due to the rapid backflow. So I talked about it, every murmur in diastolic flow murmur are low pitched, but aortic regurgitation is relatively high pitched, and there will be decrescendo murmur due to rapid backflow. The characteristic of this murmur is that it is hard at the left second to third intercostal space, best with patient sitting forward and in end expiration, grade 2 to 4. It may include Austin Flint murmur, that is low pitched, from regurgitant jet hitting mitral valve. I talked about it. It is also low pitched in case of Austin Flint murmur. So the associated findings of this murmur is that there can be a very wide pulse pressure, water hammer pulse, a Quincke's sign, that is nail weight pulsations. You can feel nail weight pulsations, and there will be left ventricular failure in severe cases. The maneuvers are that it intensifies with sitting forward, brings aorta closer to chest wall, and it diminishes with Valsalva maneuver, that is reduced preload, because of reduced preload. So this is how you remember, like what are the systolic murmurs and what are diastolic murmurs. You can make 4 boxes and type AM, AM, PT, PT in all cases, right? In 4 boxes, you can type like that: AM, AM, PT, PT, and then here are 4 letters: SRRS, SRRS. Both are similar in upper 2 compartments and lower 2 compartments. So actually, in systolic, there is aortic stenosis, mitral regurgitation, pulmonary stenosis, tricuspid regurgitation. And in diastolic, there is aortic regurgitation, mitral stenosis, pulmonary regurgitation, tricuspid stenosis. That is how you remember. First, you will be confused, but when you understand this, how you write it down, you will be like this. Like this is like a formula, right? This is just like a formula. AM, AM, SRRS. PT, PT, SRRS. That is how you remember. So let's talk about diagnostics. How do you do the diagnostics? It is not only for diastolic, it is also for systolic murmurs and BST, right? Or shunt murmurs. Let's talk about diagnostics. We have to auscultate first, right? We have to use the stethoscope bell for low pitched murmurs like mitral stenosis, and the diaphragm for high pitched murmurs like aortic regurgitation. The optimal positions are left lateral for mitral stenosis and sitting forward for aortic regurgitation. And the maneuvers, obviously, squatting, Valsalva, hand grip. Squatting increases preload, intensifying most murmurs except hypertrophic cardiomyopathy. And Valsalva decreases preload, reducing most murmurs except hypertrophic cardiomyopathy. And hand grip, it increases afterload, enhancing regurgitation murmurs is in mitral regurgitation, right? And the other thing that we can do is imaging. Transthoracic echocardiogram is the gold standard, quantifying valve area, shunt size, and chamber dimensions. And transesophageal echocardiogram for detailed PDA or BST assessment can be done. The additional tests are ECG that detects chamber enlargement as in left atrial enlargement in mitral stenosis, and also chest X-ray identifies cardiomegaly by CT ratio, that is cardiothoracic ratio. We have talked about it in chest X-ray lecture also. Or pulmonary edema, cardiac catheterization for severe cases can be done. So this is it. This is the summary, right? And A, there is first heart sound, second heart sound, third heart sound, and fourth heart sound, right? And diastole, systole, diastole, systole. So in normal cases, it looks like that. The waves look like that. And in aortic stenosis, you can see mitral regurgitation, aortic regurgitation, mitral stenosis, patent ductal atheriosis, where the murmur is continuous, right? And in right side, there is a classification: systolic, diastolic, and crescendo, decrescendo. That is, it slowly reaches to the peak and then tapers. In holosystolic, it is continuous and in same intensity in all regions, in all timing. And decrescendo is, it starts from the peak, and decrescendo, crescendo is, it starts from the peak and slows down and then again reaches the peak. So in crescendo, decrescendo, there can be left or right. And in left, that is flow, aortic stenosis, hypertrophic obstructive cardiomyopathy, and in right there can be pulmonary stenosis. And in holosystolic murmurs, there are left are a mitral regurgitation, mitral valve prolapse, ventricular septal defect, and right is tricuspid regurgitation. And in diastolic murmurs, there can be decrescendo, that is in left it is aortic regurgitation, and in right it is pulmonary regurgitation. And decrescendo, crescendo, in left it is mitral stenosis and Austin Flint murmur, and in right there is tricuspid stenosis. So that is it. Subscribe for daily doses like this. Thank you for staying with me. And if you are loving this video, or if you have any confusion or curiosity, you can comment it down and we will do special lectures on that. I have made special lectures already for quite a few topics. So thank you for staying with me.